Dear friends, now let us look at this flow chart of pathogenesis of these changes that will produce metabolic syndrome and the NASH and the CV risk. Central to all these things is insulin resistance and obesity. Obesity paves way for decreased PPAR gamma activity. Obesity and decreased PPAR gamma activity reduce the levels of adiponectin, which is a protective hormone. Insulin resistance also reduces adiponectin. Reduction in the levels of adiponectin acts on the liver cells, the parenchymal cells, the Kupffer cells, the stellate cells, and the liver endothelial cells. And there is an increase in the non-esterified fatty acid influx into the liver, and these cells of the liver are flooded with NEFAs. Okay, insulin resistance by itself can act on the liver cells and produce fatty liver through the mechanisms of decreased leptin, increased interleukin 6, increase in the free fatty acid content of the body, increase in the PC1, and increase in the RAD, and increase in the tumor necrosis factor alpha. All these things together act on the liver cells and then produce fatty liver. Now, this fat damaged liver or NAFLD, it increases the free radicals and decreases the antioxidants. It stimulates the Kupffer cells, the macrophages of the liver, to work more and try to remove the fat. Once the Kupffer cells are stimulated and activated, they produce what is called nuclear factor kappa B. This increase in the nuclear factor kappa B in turn produces oxidative stress and inflammation. Activated Kupffer cells decrease the nitric oxide, which is endothelial protector, increase the tumor necrosis factor alpha, and decrease the ATP availability for oxidative processes. These also have a direct impact in increasing the nuclear factor kappa B. Thus, oxidative stress and inflammation are produced. The second hit, NASH with steatohepatitis. The steatosis has become steatohepatitis through these mechanisms and also through these mechanisms. But central to all these things again is a decrease in the beta oxidation of fats in the liver, increase in the other pathway of oxidation of fats and producing diacetyl glycerol and triacyl glycerol. The DAG and TAG are increased, and they increase the activity of cytochrome P450 enzymes A and even decrease the glutathione in the liver, decrease the PPAR alpha and PPAR gamma activity, and increase the expression of CBP hormones like CBP1A, 1C, and 2. All these mechanisms in the liver end up in converting a fatty liver into an inflammatory liver. Fat with inflammation, fat with fibrosis is the NASH, and this is associated with severe CV risk. The increase of free radicals and antioxidants have a direct action by themselves to produce all these changes by increasing the oxidative stress, and this is what is called the second hit, as we have already seen. So, this is in nutshell what is going on about the pathogenesis of the development of NAFLD and NASH. To further elucidate the pathogenesis of NASH, high fat content and high carbohydrate diet and lack of physical exercise will lead to hepatic steatosis or fatty liver NAFLD. In nutshell, this results in decreased fatty acid beta oxidation and then increase in the lipogenesis and decrease in the lipid export outside. This triggers increase in the cellular fatty acids because there is no fatty acid oxidation going on in the liver, the fatty acids accumulate within the cells of the entire system. That triggers 1 kappa B and nuclear factor kappa B activation, which produce vasoactive substances like interleukin 6 and tumor necrosis factor alpha. These changes of decreased fatty acid oxidation and increased lipogenesis and decreased lipid export result in insulin resistance. Insulin resistance further augments these. Thus, this chain of vicious cycle starts here and the NAFLD starts progressing. Now, what is happening on the carbohydrate front? These changes in the liver which we have seen, they have increased the cellular free fatty acids. Cellular free fatty acids have a direct action on the GLUT4. GLUT4 is the receptor for glucose. If the GLUT4s are open, glucose enters the cells. There is a decrease in the GLUT4 activity, so much so the glucose cannot enter into the cell. There will be reduced uptake of glucose by the cells, so much so hyperglycemia prevails. Insulin resistance combined with hyperglycemia precipitates prediabetes and diabetes. While these changes are taking place in the liver and in the glucose front, what is happening in the adipose tissue? The white adipose tissue is increased, that produces adipokines. As we know that adipose tissue is an endocrine organ, it produces adiponectin. White adipose tissue is not good for adiponectin. Adiponectin production is decreased, cytokine production is increased, tumor necrosis factor alpha, interleukin 6 are increased in amounts, and adiponectin, which is a protective hormone, is decreased. These changes will further augment the insulin resistance. Then, when there are endotoxins due to all this oxidative stress, cytokines that are available like TNF alpha and IL-6, the reactive oxygen species also called ROS, and toxins are generated. All these act on the compromised liver, which is already a fatty liver, coupled with insulin resistance. There will be peroxidation of the hepatocyte cell membrane, and cytokines are released from the hepatocytes. Stellate cells or the supporting cells are activated. There will be inflammation, there will be associated fibrosis, which is nothing but non-alcoholic steatohepatitis or NASH. Having seen the various pathogenic mechanisms or the pathways of pathogenesis, can we do something to halt the progress? What are the treatment strategies? Look here. High fat and carbohydrate diet, lack of exercise should be primarily tackled. This is the primary cause that has to be tackled by proper diet and physical exercise. Of course, chemicals like orlistat, sibutramine, rimonabant also do help in reducing the total fat load and obesity. Bariatric surgery, gastric stapling, gastrointestinal bypass operations, these reduce the absorption of nutrients and decrease the obesity. Of course, once the hepatic steatosis or NAFLD develops, that produces all these changes in the liver, and these can be countered by the use of PPAR alpha and PPAR alpha stimulators and the statins. Statins and gemfibrozil act in a favorable manner and reverse these changes in the liver. Of course, when we have the white adipose tissue formation, more diet and exercise is the only way to bring down the load of the white adipose tissue. With the result, the adiponectin will become more, and the cytokines like TNF alpha and interleukin 6 will be brought down. How about the endotoxin, cytokines and ROS and toxins? Using probiotics, UDCA, and then antioxidants. What is UDCA? We will see a little later. in the subsequent slides. These are supposed to have a positive effect on these factors and reduce the oxidative stress. Once the insulin resistance develops, then of course metformin and glitazones will help in decreasing the insulin resistance and increasing the insulin sensitivity. So much so the second hit is altered and the peroxidation of hepatocyte cell membrane is reduced and NASH can be prevented. These are the various treatment strategies which could work to halt the progress of NAFLD and that into NASH. This is in summary all the slides which we have seen in the last 4 or 5 slides depict us the pathogenic mechanisms or the pathogenesis of NASH and the probable treatment strategies for controlling these. Next we will see something about the clinical aspects, the risk factors and other things about the fatty liver.